Hello, this is Sinuses tutorial in pediatrics presented by the SchrDbb with reference The Practical Guide to History Taking and Clinical Examination by Anwar Qais Saadoon. So we are going to deal with sinuses. So what is sinuses? Sinuses is just defined as a bluish discoloration of the skin, mucous membrane, or nail bed. So if you have bluish discoloration of the skin, mucous membrane, nail bed, that's your sinuses. It's divided into two. You have peripheral sinuses, which is the discoloration of the skin and the nail bed peripherally, and you have central sinuses, which is now the discoloration of the mucous membrane, that is the lips, the tongue, and then the inner mouth. So usually central sinuses exist with peripheral sinuses together, and when you have central sinuses, you much more think of a cardiac origin of the sinuses. But when you have peripheral sinuses, you can think now of the a respiratory origin of the sinuses, except the respiratory origin of the sinuses is very severe for you to think that it is a respiratory origin. So before the respiratory origin of the sinuses can result to a central sinuses. Okay. So it is usually caused by increment in concentration of unsaturated hemoglobin. We need to know that what sinuses is just as a result of when you have deoxygenated hemoglobin, that's when sinuses is produced. You need to know that what when you have at least 7% of the oxygenated hemoglobin, that's when you can visualize sinuses. Are you getting? So you should have at least 7% of the oxygenated hemoglobin for you to visualize sinuses. And now I need to point out the fact that sinuses can tell you that there is a poor oxygen in blood, but it is not a very good method to assess for oxygen level in blood. If you want to assess oxygen level in blood, it's better for you to use your machine called a Satori Method. And the Satori Method is the one that is, or the oximeter is going to be used now to measure the percentage of hemoglobin which is oxygenated or not. Are you getting? And I want to also point out the fact that what in case of anemia, when the patient is anemic, it is difficult for you to visualize that the patient is sinused. Are you getting? Because in anemia, there is a decrease in percentage of hemoglobin in blood. Since there is a decrease in percentage of hemoglobin in blood, the patient, though has a low level of oxygen in blood and has a low level and has a high level of deoxygenated hemoglobin, you may not visualize it in or with sinuses, because in this case the patient do not have enough hemoglobin for you to visualize the deoxygenated hemoglobin as 7% into a clinical sign as the sinuses. I hope you understand it. Okay, sinuses is central or peripheral. Any child with sinuses require careful assessment to exclude congenital or acquired respiratory cardiac diseases. So those are the two main: respiratory cardiac disease, which can be congenital or acquired in origin. So respiratory disorders are most common cause of life-threatening sinuses in children. So the next one now, sinuses. Where is your history taking sinuses? You start with identification. You have the age, if it's a newborn, if it's an older child. Chief complaints. So the chief complaint, sinuses, as you cannot say sinuses as a chief complaint. You're going to say bluish discoloration of the skin, the lips, the mucous membrane. That's what the patient tells you. So history of presenting complaint. So on the history of presenting complaint, you have onset of sinuses, can be sudden or gradual. The duration, that is acute or chronic. The timing, is it in the morning, the night, or when doing exercise. So location, which part of the body is affected for you to say if it is central or peripheral sinuses. You have the frequency of cyanotic episode. Is it intermittent? Is it continuous all through the day? Or you have is intermittent, coming in the morning, then in the afternoon, then in the night, after every 1 hour. Is it continuous or intermittent? That's the frequency. Is it associated with symptoms such as dyspnea? So you have to always see the associated symptoms. If there is dyspnea, if there is cough, you can think of a respiratory origin. If there is wheezing, you think of a respiratory or even a cardiac origin. So you have stridors. If there is fever, if there is excessive crying, you have to identify all that. Now you have the precipitating, aggravating, and relieving factors. You think of precipitating, aggravating, and relieving factor. You think of exercise. You have exercise. You have feeding, crying, spatial positions. So precipitating, aggravating factors. You have relieving factors. You have exercise, feeding, so crying, and spatial considerations. You have chest trauma. So all those are you are going to visualize. Now on the past issue is also very important in this patient who have sinuses. Does the mother, in the past issue, you try to visualize anything that can prone the child to have a congenital disorder. A congenital disorder can be either associated with the lungs, or as we have said, associated with the respiratory system or the cardiovascular system. So maternal diabetes can prone the child to have any of these. So maternal diabetes can prone the child to have an immature lung, as I've initially told you. Maternal diabetes usually occur as from 26 weeks of gestation. So it's going to result for the child in having an immature lungs, I've told you. So the maturation of the lungs is complete only after 36 weeks of gestation in the child from a mother having maternal or gestational diabetes. You have to know drugs used during the pregnancy and the time when the drugs have been used, because those drugs may be teratogenic. The next thing you have to know, if the child has polyhydramnios, if the child has oligohydramnios. Oligohydramnios, you need to know that what amniotic fluid is used in the maturation of the lungs. I hope you know that amniotic fluid is used in the maturation of the lungs and many other systems. So if the child has oligohydramnios, it's not going to be enough amniotic fluid for the maturation of the lungs. And if the child has polyhydramnios, you may think that there is an obstructive disorder, an obstructive congenital malformation which has occurred, which prevents the child from swallowing the normal amniotic fluid level. Rupture of membranes. Rupture of membranes, if the rupture of membranes had occurred before the normal time of maturation, because normally the lungs should mature by 34 weeks of gestation. If the rupture of membrane occurred less than 34 weeks of gestation, the child may be sinus. Why? Because the lung has not yet matured. You have prolonged labor, other things. Prolonged labor in case which can result to acute fetal distress. Meconium stain amniotic fluid can result to meconium aspiration. A history of birth asphyxia. Gestational age, birth weight. So all that is very important. The past medical and the surgical issue. You have previous episodes of sinuses. You have child age when the first episode of sinuses occurred. So you have to know previous episodes of sinuses. You have the child age when the first episode of sinuses occurred. You have congenital heart disease. You have prior lung disease, e.g. asthma, neurologic disease, and all that. So the next one now is the medication issue. As I've told you, there are certain medication that are going to be teratogenic, and even present medication that can result to sinuses. Example, amiodarone is a present medication that can result to sinuses. You have, so because it can cause methemoglobinemia. And what is methemoglobinemia? Methemoglobinemia is not actually deoxygenated hemoglobinemia. Are you getting? So methemoglobinemia is just that you have, at the place of the normal iron 2 ion which is present inside the hemoglobin, there is iron 3 ion. Are you getting? So Fe3 plus is going to be the one that results to methemoglobinemia. So it's going to actually, the child does not have deoxygenated hemoglobin that is perceived as the true sinuses, but you have instead a false sinuses as a result of methemoglobinemia. So it can also be produced as a result of antibiotics, sulfonamides, and anti-malarial drugs with amiodarone. So we have developmental issue. In the developmental issue, how is the child's development? The feeding and dietary issue. Feeding, is it breathing fast when feeding? So you can think of a tracheoesophageal fistula when you have this. Family issue. Is it a family issue of asthma? Is it a family issue of hemoglobinopathies? Is it a family issue of congenital heart disease? And also a family issue of birth defects. So all that is very important. Then social issue. You have contact with anyone who has infectious disease, drug abuse, exposure to oxidants, toxins, smoke inhalation, and cold exposure. it makes in newborns, maternal diabetes may be associated with a newborn and other. You have to know that what maternal diabetes may be associated with cyanotic congenital heart disease. So that's one that's associated with maternal diabetes. It's associated with neonatal hypoglycemia and associated with neonatal polycythemia. So all these can result to a cyanosis. So maternal diabetes is associated with cyanotic congenital heart disease. Maternal diabetes is associated with so this is not actually gestational diabetes. I hope you understand. There's a difference between gestational diabetes and maternal diabetes. It was why I did not give a suitable. If you have a child from a mother that has gestational diabetes occur only as from 26 weeks of gestation. By that time of 26 weeks of gestation, the heart is fully matured. All organogenesis occur in the first trimester. By that time of 26 weeks of gestation, the heart is fully matured. So it's impossible for you to have cyanotic congenital heart disease if you have a mother with gestational diabetes. It's only possible for you to have long immaturity, because the complete long maturation occur till 34 weeks of gestation, and gestational diabetes impairs the normal long maturation. So if you have a mother gestational diabetes and that the child has a cyanotic and that the child has cyanosis, you should first think of long immaturity. But now, if the mother has maternal diabetes, what do I mean by that? Maternal diabetes, the mother is a diabetic patient. That is, before the pregnancy, the mother was already having diabetes, and that diabetes is going to impair down to the organogenesis. That is why in that case you can have a cyanotic congenital heart disease. You can have polycythemia, which is involved in the bone marrow production, and you can have neonatal hypoglycemia. So all these are the three that you have in case of a maternal diabetes, and all that can result to cyanosis. Now, polyhydramnios is associated with fetal airway. So if you have fetal airway, esophageal and neurological condition, mostly fetal airway obstruction. If you have fetal airway obstruction, you can have polyhydramnios. If you have esophageal airway obstruction, you can have polyhydramnios. If you have any neurological condition which impairs swallowing, you have polyhydramnios. So we have oligohydramnios. Oligohydramnios now is associated now with pulmonary hypoplasia, because I've told you that the amniotic fluid is involved in. When I say polyhydramnios, it's just meaning that you have much amniotic fluid, and when I say oligohydramnios, it means that you have small amniotic fluid, and the level is, for polyhydramnios, it has to be greater than 2 liters, while oligohydramnios is when it's less than 500 mils by the level of 30 to 36 weeks of gestation. That is the range at which you speak about those liters and all that. But they say, but you need to know that what at every gestational age is a particular reference value of amniotic fluid that is used. So it may be associated with polyhydramnios and renal defects. So the patient does not urinate well. We need to know that what amniotic fluid is produced from 1, the maternal blood vessels, 2, the child's excretion, and 3, the child swallowing. So all those are the effects that can result to the production and the reduction of amniotic fluid. So now the next one is meconium staining. So meconium staining can be associated with a meconium aspiration syndrome, as I've initially told you, and you also have a persistent pulmonary hypertension. So meconium staining is associated with 2 things. You have, so if you see meconium amniotic fluid, you can think of 2 things. The first thing is meconial aspiration, and the second thing you think of is persistent pulmonary hypertension. Meconial aspiration and persistent pulmonary hypertension. Now, in older children, that was in neonates, in older children, the persistent cyanosis may be caused by congenital heart disease. So if you have persistent cyanosis, you think of congenital heart disease. You think of a primary lung disease, any primary lung disease. You think of pulmonary artery hypertension. pulmonary artery hypertension can result to that. And we said that persistent pulmonary hypertension is treated in neonates with Meconium Staining. But here we think of pulmonary artery hypertension. The first is congenital heart disease. The second is a primary lung disease involving the airways. The third is pulmonary artery hypertension involving the blood vessels of the lungs, and we have abnormal hemoglobin. So that is a cause of persistent cyanosis in older children. A ratio of crying followed by sudden breath holding. If you have a child who cries and then suddenly breath hold, you think of a cyanotic breath holding spells. A cyanotic breath holding spells, and usually this cyanotic breath holding spells are associated with congenital heart disease, or it can be alone, it can be an idiopathic, or it can be a non-problematic cyanotic, a physiologic cyanotic breath holding spells. Here the child is going to cry. When you cry, you have expiration, but the child do not breathe in. So he expires, he cries, and then he holds his breathing. He does not breathe in, and then he cries, he's holding his breathing. So all that is going to result now to cyanosis, and the patient may get to, he may lose consciousness. Okay. So cyanotic death spells or breath holding spells occur after children wakes early in the morning. Mostly it occurs after the children wake early in the morning. So from that we are finished with cyanosis. We say thanks for your kind attention.